We're really pleased to have Alan Plutchock with us. Alan has been very generous with his time. He's a retired MD who is using his time in other ways, hiking and doing other such things, but he's fit us into his schedule. As you can see from the title of the program, it's Help, I've Got a Diagnosis. So we're going to have an entire day of question and answer. I sent in an email and mentioned that to you. So I'm going to begin by asking Alan some questions and then turn it over to all of you to get your questions answered as well. Yesterday, Alan and I were talking and he was educating me about the hospital, how they evolved and how different they are. And I suggested that he should begin by talking a little bit about this because there may be other people like me who don't have a perspective. So Alan, why don't you start and talk about that?
Start with, I'm going to tell you that all of this is my personal experiences. Some of it's research. I practiced medicine in Toronto County for the last, well, for over 35 years. And basically and I've practiced both in private practice and with Kaiser. The last 22 years I was with Kaiser. So a lot of the information about access to systems is possibly of only value for Kaiser. And I'd like people who are in private practice and who have to use insurance companies to chirp in and tell us how that works. Little background, I grew up in New Jersey, went to Rutgers College, Georgetown Medical School, then went up to Boston and did 2 years at Tufts New England Medical Center, which I can tell you was not a Harvard hospital. Then was unhappy in Boston, came out to Mount Zion and did another year of surgical residency at Mount Zion, which was a really first-class private hospital, spent 2 years in the Air Force, and then came back to Vallejo and went into family practice, although I had a surgical background, but not board certified, as a family practitioner with Family Doctor Medical Group, ran an ER. I basically took care of people, as you'd say, from womb to tomb. I delivered babies. I went out and pronounced them at home. I ran an intensive hospital practice, did up to sometimes 8 or 10 deliveries a month. Also became a medical director of an HMO in Vallejo in the late 70s, and then was qualified to certify other HMOs as to their qualifications. And at that point, I went to national meetings and learned about where healthcare was going and how it was planned, and realized that the doctors were about 10 years behind any of what was happening. It was all planned and gone. And then they started talking about a ship that was already 100 miles or 200 miles off the coast, and they were not going to get on board. And basically, I'm going to tell you some opinions about what I think about the healthcare we get in the United States. And I'll start off with saying it's not a system. It's not a plan. It's healthcare. And I always think that a lot of life, you have to go back to history and genetics and embryology, and you can look at where it is and why it is and what's happening. So I'll go into somewhat of the healthcare system of the United States and give you my opinions. And basically, we all came to this country as rebellious people. Nobody left and came here because they were so wealthy they didn't need to come. We all had our ideas and we're going to do it our way. And basically, and none of us had agreed with the other ways it was being done. And I think that right now we all can agree that's pretty much what's happening. So we got here in the 1700s. The first medical society was in 1735. The first hospital was in Philadelphia in 1750. The first medical school was in 1765. And basically most of it was an apprenticeship program. Wars have made medicine better. You go to war, you are basically faced with disaster, and you start figuring out how to deal with it. The Civil War, we learned about the Union won for only one reason. The Union won. It's because they put their outhouses further away from their water supply than the South did, and it was all a matter of health. And we learned how to amputate limbs. World War II was disaster. We learned a lot more. We also started building hospitals. We had a VA system after the Civil War. In 1849, we had the American Medical Association finally was formed. And by 1899, 50 years later, after the AMA was born, they finally got to 50% membership of the physicians. And I'd have to tell you, I never was a member of the AMA. They didn't represent a lot of what America needed for healthcare. They've been against full-time healthcare and a healthcare system. And finally, now recently, Kaiser has decided to enroll all of their physicians in the AMA so they can get power and get them to possibly behave the way we need for healthcare, as say. The other thing is most all of healthcare was from charitable organizations. So none of it was ever organized to be a functioning business. They were all charities, and they were run by the churches, by the every other group. And then the first time anybody decided that healthcare was a good idea was Theodore Roosevelt. And he felt that healthy people made for a healthy society. And the unions wanted to protect the workers. Unfortunately, it wasn't going to work. In 1915, the American Association of Labor Unions had this whole big thing of a whole movement to get health care. And initially the AMA supported it, but the local societies, each state society, wouldn't back it. So the AMA then wouldn't back healthcare in 1917. So there was our first time trying. Even the AFL, the AFL didn't support it. In 1926, we had another attempt to getting healthcare. FDR was really to give us healthcare, but he did get through with Social Security, which the AMA opposed. And if you look at and you ask the people right now what their favorite government support would be, it would end up being two things: Social Security and Medicare. So anyway, all the time we keep coming back to giving people health care, and we always come back to opposing it. In 1943, there was a National Health Care Act coming in, and then they said it was socialist, and it was all red baiting at that time and undermined it. Truman couldn't get it through. Lyndon Johnson finally got through the Medicare bill and also Medicaid. And that was threatened by the AMA. They would not support it because private physicians weren't going to get enough. And the reason we have this Part A, Part B ends up because of that. Kaiser came through only because Henry J. Kaiser and Bechtel and these guys were building these huge projects out in the desert, had 6,000 employees and no health care. So they decided that basically they will hire the docs and get their health care out there. And then the families moved by, and finally the union said, why don't we take out 25 cents a week from your salary and deliver health care for all of you. And then after the war, basically there was a control on increasing salaries. So what happens is the unions decided, and with employers, that if I can't give you a higher salary, I'll give you more benefits. So therefore, the health care benefit came as a significant benefit to health care. And the shipyard workers in World War II, it was all stabilization. finally, in 1950s, the medical advancements came from World War II, and that ended up being penicillin, Salk vaccine, kidney transplants, all came about. The Korean War was MASH. Vietnam War was basically having these critical care units, the emergency room, moving people around. But my comment is that we've never been able to really develop a system that is organized and all together. So Kaiser's about as good as it gets. And again, it's what you have, but that's my opinion.
Thanks, Alan.
And that's opinion above knowledge.
Yeah. So going from the macro to the kind of, I wouldn't say it's, no, I'll just say, let me shift to the program, the title of the program, which is Help I Have a Diagnosis. So I am pretty ignorant. So my first question is, what's the difference between a diagnosis and a prognosis?
A diagnosis ends up being, and again, it comes down to, you have to have a medical reason and something that's in control and you can put in a computer to get paid. So the diagnosis is what you get paid by. But also, if you're talking about healthcare and end of life, it's a matter of a tissue diagnosis for some, or fitting into a group of criteria that are set. So you say, oh, if I have arthritis, I have 6 of the 10 things you need to be qualified as arthritis. And that's a diagnosis. And then the tissue diagnosis is usually a biopsy. And coming up with it, or a lab work that makes you a diabetic because you're above certain levels, or certain things on X-ray for neurological diseases. A prognosis is somebody then telling you, this is what the future is going to look like with this diagnosis, and this is what we need to do. And when you start with a diagnosis, the first visit usually is, I come in and I have a cough. And the physician's going to say, oh, I want to do this, that, and the next thing to look at your cough. And they might sort of express anxiety about what they have. If they feel a lump in your breast, they might express anxiety, but they're not going to really be firm as to what's happening, because you don't have a diagnosis till you have a diagnosis. So sometimes you feel a lump, you're really concerned, and it ends up being benign. So you don't have something bad till you have something bad. You know, although you walk out with other feelings sometimes. The prognosis is somebody knows, and there's statistics that will tell you, with this disease, you might go anywhere from 6 weeks to 6 years, and they can give you all of this formulas that the different associations have, heart failure, different ideas, but it's just guesses. So some people end up doing really poor and they don't make the distance they're supposed to, and other people miraculously go well beyond it. And my guess, what I tell you is, when somebody gives you a bad prognosis, you have to think the worst, but act for the best, and really, and you don't know. And what's going to happen is you're just going to have to be flexible. And it's really lousy and miserable, but you got to just, this is it. You don't control it.
So then when you're working with the doctor, if you would actually, everyone put yourself on mute except when you're answering a question, that would probably be helpful. So Alan, what is a care team, and who sets the goals of care, and how does that happen?
Well, I think you jumped quite a bit. Which number are you at already?
Oh no, I could go in order if I have.
If you don't mind,
Yeah. Okay. So actually, you're right. I did jump. So I like the question that says, when you get a diagnosis, what kind of questions should I be asking the doctor?
Yeah. When you get the diagnosis, I think the first thing you have to do is take a deep breath. The second thing you have to do is acknowledge that everything they told you after you heard it, you didn't hear. You just basically shut off. You know, I got cancer, and if they, whatever the hell they're going to tell you is gone. You just, you know, the floor fell out, period. But what you need to do is find out from them, okay, this is my problem. How are we going to manage it? What's your plan? Who do I see next? What do I do next? How do I go about it? Now, my problem is I can tell you how Kaiser would do it. So they can just send out a consultation to a surgeon, to an oncologist, to a radiologist, whatever they like. There's tumor boards. But they're also in the diagnosis, congestive heart failure, COPD, and other end of life, other neurological diseases have to come into play. So they're also seen by specialists with everything else. So it's not just a cancer diagnosis. And again, with those diagnoses, people will say congestive heart failure can have a number and it sounds really bad. And 10 years later, they're still around with that number and haven't done as poorly. So, but there's care for all of those other diagnoses. And some people just end up dying of old age. And it happens. You just run out of steam. Some people don't have the answer. But the next question is, you need to get what a plan is and how you're going to deal with the plan, and then get second opinions on it if you need be. But you have to have somebody lay out a plan. In insurance, you're going to have to get them to have approval of the next step. And that, it sounds like, can be real disastrous for some people, getting that next step done.
But you're saying it sounds like a disaster?
And that sometimes they really postpone.
Oh,
They won't get you to the next step in the time frame. Unfortunately, time frames are very, once I have a problem, I want the problem fixed yesterday or today. And quite often, it's not quite as bad as that. So, I mean, if you have a diagnosis of breast cancer, the cells don't grow that fast, and a week or two, or even 3 weeks or 4 weeks might not really change your outcome. Emotionally, it does, but it does not change your life expectancy. And it's really hard, but that's a question you have to ask. Is postponing that horrible? You know, I have a lump. I plan to go see my grandkids next weekend. Is that okay to wait? So there's the difference between emotionally what you need and what's really harmful to you that you have to separate out.
so I've had experience with friends who haven't got a diagnosis, and then it felt like they waited and waited and waited for the system to respond. And that was frustrating. They were anxious, and as you said, emotionally, they're ready to go.
It's basically, I guess the word, and I later on you asked, and I have it, you have to be your major advocate.
Yeah.
And I ended up looking up the definitions of advocate, and because I think you need to know what they are. It's a champion, a battler, a crusader, a pleader, an apostle. And then basically it's a miserable job you need to, that's handed to you, but it's your job, and you need to, if need be, ask other people to help you advocate. But it goes back to the goddamn system, to put it bluntly.
Yeah. Yeah.
I'm being honest with you about this.
Yeah. Yeah. No, I appreciate
I'm
that.
not going to come out with painting it pink.
So, Alan, one of the other things I've learned from friends is that they get a diagnosis and they need to see 2 or 3 doctors. As you said, it might not just be one pigeonhole.
Right.
And then the doctors have different points of view and different tests they want. And so I've had friends who feel at effect of this, that it's not moving the way they want.
Some of it, though, sometimes some of the new testing they do they're able to, after you get a diagnosis of a cancer, they need to do all sorts of different genetic testing on it and looking at it in different ways that are not just the simple tests that you just sent in, and by the time you got back from the hospital, you already know what your blood sugar is. Some of these are very sophisticated tests. Occasionally, there'll be a tumor diagnosis in which two different pathologists might have different opinions, and they'll send them off to other people to get a second opinion on the diagnosis, and you're left hanging. But unfortunately, there's not much you can do other than be patient, because some of these are more complicated issues than others. And I wish I could have an answer. But again, a little side is that right now, with all of these new cancer drugs, this drug, a small example is this drug Herceptin that's used for breast cancer. When they did the initial trials on it, half the people had this miraculous cure and half of them had no effect at all. So they decided that the drug wasn't a good drug because it only had 50% effectiveness. And then they went back and said, why was it so effective on 50%? Well, it was a genetic thing with a sensor. So once you can mark the different cancer cells and find out which drug will work and which won't, then you can pick therapies that are more significant, which really changes a whole outlook and a whole picture. And it's like somebody handing you a bunch of keys. If it was marked and you use the right key, the door opens. If you have to go through all of it, you've wasted a lot of time. So sometimes this takes more time to get these tests back.
So our first speaker talked about the fact that she recommended we don't allow anyone to act on a procedure until we find out what it's for and how much it's going to cost.
Well,
does that make sense?
It doesn't. It doesn't. Again, because I was a member of Kaiser, what the procedure is going to cost is only what your copay is. And I think, so in that portion of the system, whether you had your ingrown toenail, once you're going, there's not a difference in charge between a major surgical procedure and a minor surgical procedure, or I think hospitalization and non-hospitalization. Unfortunately, doctors really don't know much about billing and all that, and you have the front office, so you need somebody else to really help you with that. But I'd say, and somebody should always be explaining what the surgical procedure is and what the outcome is, and how optimistic they are or not.
Thank you. Thanks. So let me get to that question that I was asking earlier about. So who sets the goals of care? Am I just, if I'm in the hospital with some diagnosis, is some doctor just going to tell me this is it?
Well, to start with, there's two parts to decision-making. And initially, all of it was paternalistic, and the doctor told you what you were going to do and how it was going to happen. And now I think there's a large portion of it that's shared decision-making. And I think that if you want to share a decision making with your physician, you should tell them that I need to be involved in the decision making, and I want to share in your decisions. However, as far as the complexity of chemotherapy and some of these fancy drugs, it's really hard for you to sort through them, and you can, and you're welcome to get back to them. But some of it also is protocol. So if you have a certain type of a tumor, there's usually been experiments and outcomes that the Cancer Society has looked at that says when you have this is how you fix it, and this is the way you go down the road. And the first line drug is this. Now, you might disagree with them. You might want a second opinion. And I know that on certain cases, Kaiser will let you go for one visit to a university hospital, to either UCSF, Stanford, Davis, for a single visit with a physician there to get a second opinion. So you have to ask for it. Most everything doesn't come out till you're really turn over innumerable leaves and ask and ask and ask. I wish I could tell you something different.
I realize. Advocate, advocate, advocate. That's the other thing that I heard you say.
Yeah. And it's not a nice job.
Oh,
I'm being very negative, but I'm being very honest.
yeah. You know, here is something that I've read about and unfortunately feel like I've heard a number of times, that the doctors don't, what do I want to say? Don't respect the points of view of older adults.
I don't think that's true myself, but that's only because, I always respected them. But I think that, again, one of my thoughts are, I think that you have to pretty much, if you feel that way, express to them and tell them about your vitality. Tell them about your experiences. Tell them about what you're doing, that I hike once a week, that I'm still maintaining my house, that I'm still doing this, that I'm caring for my grandkids, and make it personal to show them that you're a valuable, you're not just using our air.
And what about you? You made a comment that stayed with me when we talked yesterday about preparing your doctor for a visit by sending, well, I'll let you talk.
Basically, I always felt that if somebody would come in with a shopping list, it was my favorite thing to see somebody coming with a shopping list. We don't go shopping without our shopping lists. We don't remember anything. And I think you need to have in writing everything that you want to talk to the doctor about. And I used to drive the advice nurses at Kaiser crazy, because I said, the only thing I want to know what the patient's calling about is, what do they want? I mean, when you go to a hospital, a doctor's visit, I think you have your line has to be, what do I want? I need to know what this is wrong. I need this medicine. I need to see this person. What do I want? And I think that's what helps. But I think that if you really have a long list, it pays to organize it. And if you email your doc often, send it to them soon, because sometimes somebody will have a list and they're talking about their ingrown toenails and their dandruff and this, that. And number 7 says, every once in a while, I feel my heart's running irregular. Chest pain walking up the street, up the steps. Well, that's a lot more significant than my talking about your dandruff or your skin tags. So I think I might get out of order and go that way. But I think you need, and the other thing is, I think if you can copy it and give him or her one copy, and you sit there with a pen and knock off what they said. If you get there and there's something really significant, they haven't answered it, ask them. And Kaiser, when they sent you to charm school and all the docs had to go to charm school, at charm school, they said, before you leave the door, when your hand's on the knob, ask them, have I answered all of your questions?
Mm-hmm.
And that was how you won at charm school.
So the other thing you said, Alan, which I had never thought of, was, because I always prepare my priority list, but you said, so send it to them early, send it to them by email.
Send it to them. Email really works. At first, it was this disaster, the thoughts of having to deal with an email. And again, and I know Sutter has the same system as Kaiser. So if you send a physician an email, your medical record's attached to the email. So if you have a question, they can go look at it right then. They can look at the x-rays. They can look at the drugs you're on. So they're really prepared, and it makes it so much easier for them. And if they really see that it's going to be a big problem, they'll probably emotionally be ready to spend more time with you, do all that, and really find out. If they're unhappy with it, they'll tell you, but I think it would work. And I really was always happy when somebody emailed me or or left a message that I couldn't see. But every once in a while, I used to give people my line directly into my office, and two things would happen. Sometimes they just call and tell me their whole story, but never give me their Kaiser number or their name. And I just shake my head and said, oh shit. And that was it, because I couldn't respond to them, because you have to tell them who you are and what your phone number is. and and a Kaiser number or your medical record number if you need be.
Yeah. And the other thing Alan said, that he thought that if you prepared in advance, not only prepared in advance, you sent it in advance, that many doctors might look at you as you're functioning professionally. Yeah. And have a positive response, which I think would always be building a good case for yourself.
And the other thing I'd probably throw out right now is if you're going to have a visit, if they offer you a telephone visit or a video visit, we're all using video. I think you have a much better relationship with a video visit than you would with a doctor visit. And I mean, I had a video visit with they offered me a video visit with a orthopedic surgeon. He said, it's useless. I need to show them things. I need to talk to them. I said, I'd like to have a telephone visit, a television visit. And I ended up putting a mark on my shoulder where my pain was. I ended up having some weights in the room and showed them what I could do and what I couldn't do. And it's just more functional, the televisits, if you can deal with it.
Yeah.
That would be my suggestion.
That's great. So actually, I'm going to stay with that question, which I was really at the end, which was saying, what do you do as a patient, not as a doctor, to try to get the best possible benefit from the healthcare system?
I'll tell you, it's really, we're right now, and it's do as I say, not as I do. Not happy with our primary care physician. I think he's a great gatekeeper for Kaiser, but he's not an advocate. I think you really have to look for physicians who are advocates. The system, a quarterback isn't much of a quarterback without a lineman. And basically, your primary care physician's your lineman through the system.
Yeah. So that takes me back to what ends up being, let's say I have a diagnosis of breast cancer. What is a care team? How is that assembled? Do I have any voice in that?
Some. I think that usually if you can know the name of somebody who you want as a referral, you can ask if you can have that person as a referral. If you're, again, I only know the Kaiser system well, but in private practice, my guess is if you have a breast cancer, your physician would know the oncologist they'd like to refer you to, and the team. I don't know about tumor boards now, but there used to always be a tumor board that a tumor would go to, and they would discuss it and have recommendations there, whether you needed surgery or oncology or radiology. But you can ask for it. Usually it's the next person available. It ended up really, when I was at Kaiser, it blew my mind away, and that at least in Vallejo, if you saw somebody who had a breast lump and you could feel it, there was one of the pathologists really liked to do biopsies, and it was always available. And my God, some morning I'd call and I'd see the patient in the morning, and I'd have a tissue diagnosis back the same day. And then once you have the tissue diagnosis, you can hustle the surgeons ahead, and they will then, because they know what they have to deal with, move you to the beginning of the line. But then they end up doing stuff that they want to have done. So sometimes you need to have special dyes inserted before you're going to have a biopsy and stuff like that. And it takes time. Some of it is, you can always ask the question, is this 2 weeks wait, is it going to be significant? And emotionally it is, but quite often, as far as longevity goes, you probably were dealing with this cancer for maybe a year or two in your body without even knowing you had it. But the moment you have it, you want to fix it.
Yes. Yeah, for sure. I have some more questions, but I thought I would open it up to see if there are others who have questions that you would like to get answered before I fill it up with my other questions. Is there anyone with a question you'd like to pose?
Donna was there. Donna,
Cynthia, and
Oh.
unmute yourself.
Okay, hi, thank you. I have a question. What is the capacity for Kaiser? I know they're like, provide the most medical care here in Solano anyway. And so I always wonder, how many people can they keep taking on? I mean, is there maximum? Is that legal? I mean, it just seems like.
It's all controlled by the state with your licensing. And as far as that goes, since I've been around, they've opened up a Vacaville hospital, they have an Antioch hospital, they have a Walnut Creek hospital. So they've really increased capacity markedly. They are pretty lucky in that it's because of the benefits, they really are able to hire physicians pretty much as needed. And they have just opened up their own medical school down in Southern California.
Okay, thank you.
Who else had a question? Cynthia?
Yes, thank you. I was wondering if you could recommend some good sources, reputable sources, scientific resources for us to learn more about a particular diagnosis or condition. And I would include in that if we've been prescribed a medicine and we want to find out about side effects and things like that.
Basically, I would say that the best websites are those like Stanford, Mayo Clinic, WebMD, UCSF. So if it's a university website or the American College of Gynecologists, American Gynecology, Orthopedics, any of the organizations that are certified, those would be valid sites. When I took a class many years ago on how to research, the question they asked was to look up hiccups. And if you look up hiccups, the first person was Dr. Hiccup, who came up on your review. And Dr. Hiccup's cure for the hiccups was to hold your breath for 10 minutes. Well, it was always successful,
Right.
but it was bad information.
Yeah.
So you really have to look up who you're getting your information from.
Yeah. Yeah.
Thank you.
Yeah. Anyone else with a question you'd like to pose? Okay, Mimi, unmute yourself.
I would imagine that first that first planning session, so to speak, would be with your primary caregiver. The question I have is, as you go through your treatment, is that primary caregiver someone who can help advocate for you?
They can. I would have to say that when you get into oncology and those drugs, there's a really, really sophisticated group of medications that your primary care physician really just doesn't keep up with. I mean, it's just, they're so specialized and they keep changing so fast. What we haven't talked about, which I know you're going to really have a pile of sessions on, is both hospice and palliative care.
Yeah.
And I think those are really resources. And if you're in chemo, the chemo nurses are just incredible people there. And they can really advocate for you. And I know that Jeannie Heyman, her not-for-profit, takes care of cancer, and she has arrangements. And I know with Kaiser too, that the chemo people, if they know that you're having problems paying rent, if you're having problems with gas money, that they have the ability through Jeannie Heyman Society to give money to people just a Costco credit card to go get gas. And the nurses, the chemo nurses and the chemo, no. So, and it's really, wherever you can find an advocate, grab them.
Yeah, yeah. Okay, Constance?
Thank you. Thank you. What I'd like to do is thank you, Alan, number one, for all you do for Carquinez Village and especially for this program. And whoever was so kind to deliver my packet of information. I had a chance to look at the NIH National Institute of Health website, and they have a ton of information that is really beneficial. But my question is, how might we consider when enough is enough? And how do you communicate that to your physician and care team?
Well, my answer with that is the physicians wait much too long, in my opinion, to use hospice. So when you're uncomfortable with how life is going, ask them about hospice and palliative care. The difference between hospice and palliative care is somewhat a term that hospice is a formal thing that Medicare gives you. You can stay for 180 days. If you haven't died in 180 days, they discharge you, wait 48 hours, a week, 2 weeks, and if you're not doing well, they readmit you to hospice. It gives you a lot more services. It does not deny you the right for care. It does not say that you can't take chemo, but it does give you a lot more emotional support. The decision when's enough is yours and yours alone. I think that we have basically told people that dying is failure, and that's wrong. I think that we say giving up is wrong. I think we use the term battle is wrong. I think there's a whole pile of things.
Hang on.
What this program is, this is sort of like, I said to Judy the other day, this is like Lamaze. Many of us as families took training and we learned about childbirth. Well, I think that this is learning about end of life, which is going to be the same thing.
Yes.
And it gives us tools and like Lamaze, you planned how your delivery goes and it went the way it went. The reality, and basically with Lamaze, with this, it's going to be the same way. It gives us.
Oh, hang on.
Whoops. Someone is
For vision or hearing?
oh,
It's the caves. Can you
oh,
can you put them on
yeah.
mute?
Oh,
Helen Cave, could you ask Leonard to move to another room?
Okay. They want you to move to another room. You have to get off the phone.
yeah, and I'll probably call me back later.
He's talking about
Okay.
the PA system.
Right.
The PA system
Okay.
organized too, and
Yeah.
but you have to advocate.
Thank you.
No, they're hearing you.
Okay, thank you. That's good. We're moving on.
Anything else, Constance?
No.
Okay.
Okay, great. Anyone else with a question?
Something about the doctor and COVID or testing or, I don't know. He's gonna call back.
Okay,
Probably his camp.
all
I'd
right.
like to piggyback on what Alan talked about in terms
Can you
of
hear that?
conveying your preferences and your wishes to your doctor. One of the best things that our family did, and this is maybe 10 years ago, was to sit down with the social worker at Kaiser and do our medical directives. And you can be very, very specific about what you do and do not want done.
Yeah. One of the things we haven't gotten to that I did some research last night that I think I need to express. If you're really unhappy with what's happening, Medicare has a whole appeal process that is overwhelmingly significant that I can't go through it in completely, but if you go to medicare.gov and you write appeals in, it tells you about all of the different options you have. if they're going to throw you out of the hospital too soon, if it's outpatient care. It's all sorts of incredible options that by law they have. And the marvelous thing is, big organizations don't like to take on the government. So the moment you say, they tell you you had your hip done, and well, you're out of surgery 12 hours, it's 2:00 in the morning, I think you need to go home. It's time for you to say, no, I can't. I'm living alone, and you can't send me home now. And if they're insistent, you say, I'd like to appeal. And the moment you pull out your appeal card, it's almost like a referee there at the soccer match pulling out a red card. They have to stop. They have to start with your paperwork. It really is significant, and it gives you power. And they can't get back at you because of it. Just do it. Just do it. And look at it. Go to. It's not pleasant to do it, but do it.
I like your calling it as it is, Alan. Not a surprise. Anyone else? Jean?
No, Jean's on. Tell her she's on mute.
Oh, Jean, you're on mute.
Yeah, I just unmuted.
Oh, okay.
When I had my stroke about 1.5 years ago, the hospital felt that I was ready to leave. And I had been told that I had to go to a nursing home so that I could become strong enough to go on to another program at another hospital. I just wasn't quite strong enough. And Jack was looking at a little bit at nursing homes. He didn't like them. Many of them had COVID. This was the beginning of COVID. He was having a little trouble finding out where I should go. And I have a cousin who at the time was a hospital administrator, and I told up in Oregon, and I told Jack to call Ed and find out what could they kick me out? How do we keep me in the hospital? And Ed said, do an appeal. And Jack was really thought that was ridiculous. How is the government appeal going to work? Ed said, do it. Don't argue with me, do it. It's just the way that you explained it. It stops, everything stops. And it stopped for 3 days until they dealt with the appeal. And it also said they're probably not going to accept your appeal. They're not going to honor it in a sense, but you gain 3 days. In those 3 days, Jack scrambled around, found a place that he liked, that he felt was suitable for me to go, a nursing home or whatever it was. And I needed to be there for about 10 days to go on to the next step. And it really worked. So I want to say that if you aren't happy with something in your hospital, the magic word is appeal. It may be denied in the end, but you gain time to find more something else. And sometimes for us, it was such a shock that I had this stroke, and we just needed a little bit more time to find out what was the best thing. So there we are.
Jean, thank you for sharing your experience, Jean.
Real fast is, it used to be that the hospitals looked at it in hospital days. They look at it in hospital hours now. So they're looking at every hour they can cut out and get you out. It is what they're doing. And it's, again, I'm sorry, I'm painted the picture
Uh-huh.
right now, but go ahead.
That's great. Barbara?
I'd just like to bring up a role at the hospital that hasn't been mentioned that yet, and that's the discharge planner. I hospitals are responsible for a safe discharge legally. And so the discharge planner is who actually fills that role to make sure the discharge planning is effective and appropriate. And I understand what Alan's saying about the hours and the costs, but it's also true that being in a hospital is not perhaps the best place for you after, say, several days of having had a stroke. Generally, the step down process would be that the discharge planner would be recommending a nursing home that has a good rehab program. And in my experience, actually, they will pick the nursing home that is the closest, has the best physical therapy, occupational therapy programs. And you, by not going right home or getting home care, basically you're getting 5 days of physical therapy and occupational therapy. So if you can wait to go home for a couple of weeks, Medicare will generally pay for 2 weeks, sometimes 3 or more, after a hospitalization of nursing home care. And then after that, you can have home care, physical therapy and occupational therapy. And then after that, it generally goes to outpatient services. But my suggestion would be to have a conversation with the discharge planner before you feel like you have to go to file some appeal with the government.
That's
I
great.
agree.
Sally?
Thank you, Barbara, for the pitch for the discharge planners. I was a discharge planner at Kaiser Vallejo for the last 10 years I worked. We were obligated to tell people that they had a right to appeal. So, and of course, it was a lot of paperwork and all of that. So it was like, oh no, they're going to appeal for us, but they needed to know that. And it bought them a little time. And most of the time they don't win that appeal, because hopefully, the doctor is saying they're ready to be discharged and the physical therapist is saying they're ready, and everyone is agreed that they have a safe discharge plan before they try to discharge the patient. But they do gain a couple of days. And sometimes it's that the family isn't ready yet, and they feel like if they appeal, then they can gather the troops, that are going to come and help out. But it is a valuable service, and it is your right under Medicare. So
Thanks. That's great to understand. Speaking of that, I wanted to ask Alan, what is the role of the hospitalist? And does that person become a part of your team?
In the hospital, yes. And the hospitalists all took place after I left the practice of medicine. But in essence, it used to be you were in your office and you'd run over to the hospital and things would happen. And when I was in private practice, if there was a code taking place, you just leave. My office was close enough I could run back and forth. But it's really significant to have somebody who's in charge for 4 or 5 days, and you have 2 people, one in the day and one at night, who come in, and it's really much more organized, and they really can sort of guide you through and not drop the ball the way it was when somebody was not there for you. So I think the quality of care is improved by using hospitalists.
Oh, well, that's great. Why would a doctor want to be a hospitalist?
Because the hours are great. You work
Oh,
consistently these hours, you really intensively care for people. And then when you're not there,
yeah.
it's not your problem. And then you come back and sometimes the patient's still there and then you pick up the same patient, but you can intensively resolve problems and give good quality care and still have
Oh, that's good. I've often wondered. Anyone else with a question that you? Okay, well, I've got some more.
Okay.
So as a doctor, what do you wish your patients would know and do?
Oh, that's mostly, I think, I'd like them to know that I need to know what's wrong. So if you're miserable at home and you're uncomfortable and this is bothering you, that's bothering you, and you don't tell me, I just don't know. So I need, one of the things I think really helps is to find out what your worries are. So if you're having a cough and you're convinced you have lung cancer, tell me that I'm worried that I have lung cancer. And I can do a chest x-ray and either say, yes, I see a lump there, or no, or do, if it's really, super high risk, do a CT. But if you have a worry about something, let them know so that they can potentially resolve it. The other thing is, I think it's really helpful if you can make yourself human to somebody. Find something common that he or she remembers you by, that you were a Fisher person, or you were an artist, or you do this or you do that. And if my life's on my sleeve, so everybody knew who I was, and have humor if you can.
So let me follow that up with an experience I had, or I still have. I felt like on my chest, there is a slight, what do I call it? It doesn't feel like a lump, but it's not a normal part of me. So when I went to the doctor, she said, oh, I don't think that's anything to be concerned about. I think it might be arthritis. And so that was not long ago. Well, it was a few months ago. So I'm about to go to see her again. So we have a difference of opinion. I still think I'm not satisfied just with the message that it could be arthritis. So what do I do when I seem to be in disagreement? I guess I can go get another doctor's opinion. That's what I've been thinking. But when you have a disagreement with your doctor.
I think you can come back and just say to them, I'm really uncomfortable with just ignoring it. What would you do as the next step? And how would you reassure me that this is really nothing more? Reassure me that way. I'm still uncomfortable. It's sort of like asking somebody to validate why their thinking's going as to what it is and what their reasoning is that I feel so comfortable that it's benign.
Okay, that's helpful. That's kind of what I was thinking. Because there must be, other people must have situations where they disagree with what a doctor is prescribing.
All the time.
Yes.
Yeah. I think you've heard me keep saying opinion above knowledge.
Right.
Sometimes it's an opinion above knowledge. And some of it is, sometimes you look at something and having felt things and looked at things and things, you can say, well, this is really benign. There's little fatty tumors called lipomas that are real common, that are you just know it's okay. And skin tags and some of these other things you look at, and the dermatologic. And then there's sometimes you look and you see somebody, and now twice or three times I've been on the beach and said to somebody, I shouldn't interfere, but I'm not happy with this, looking at my friend's lesion on their arm. I'd go check it. And she went, and her primary care said, I don't know, but if your friend's uncomfortable, maybe I ought to biopsy. And it ended up being a melanoma that ended up, she caught it in time and had a huge amount of surgery, but it was just, somebody says something. Other times people come in and you say, oh no, that's just a mole. And there's ways to look at it, and you really, without biopsying, somewhat know.
Okay, thanks for that. Anyone else with other questions? So I have another one that's really just an aside, but I was, when someone said this, I was fascinated. She was saying that there are doctors who will meander into your room to look to see if they can get on your case. And I thought, really? Don't tell me that's real. So I'm curious for your opinion.
Again, I worked for Kaiser, so we were all salaried, so there was no advantage.
Oh,
Yes, that can happen. The other side of it, though, is you might end up getting bills from physicians who you didn't think you saw. So you might get a bill from a pathologist, you might get a bill from a radiologist, and you never see the radiologist. They read the x-rays and then they send a bill for X amount of dollars for having read the x-ray, even though you weren't there and you weren't seen. And there used to be pathologists who would do that. So if you're looking at bills, you might see that from people. I would have to say once when I was in private practice, another physician pretty much interfered with my care and then tried to take over the case and build big. And I ended up having to fight with this person about his interference and trying to end up doing all the billing. And yeah, it could happen.
so speaking of billing, in that case, I have this ignorant, because I really don't know, concern that you could end up, I've heard of, I heard of someone recently, that our first speaker, that her husband went into the hospital, and I don't know whether how many days, but she ended up with a $71,000 bill.
Oh,
Yeah,
And
yeah, it happens, and it happens all the time. And I'd have to say, when my father-in-law died, he had been in a couple of hospitals and this and that, and now has had to settle the estate. And probably the most successful person she found was a hospital biller who just plowed through the last year of his life and resolved most of the billing problems and worked with it. And there was one bill that was for $5,000 that the hospital couldn't account for why it was there, and just never got paid because they couldn't account for it. So yes, and frighteningly $71,000. I can't imagine what most of all of the COVID cases on ventilators, their bills are. They have to be hundreds of thousands of dollars, if not a million.
yes.
wow, oh my gosh. Well, I've only been in the hospital once, aside from when I delivered my children, but it's always something in the back of my head let's say you've got all these people you haven't seen, the pathologist and so on. Somehow your doctors must have asked for this person to come in.
Yeah, usually the other consultants, you end up, they ask for the endocrinologist, the diabetic specialist, the orthopedic guy,
Yeah.
in-care doctor to come in. When my brother was ill, he was in a hospital in Arizona. My sister-in-law was an advocate and a fierce one. She must be a lion. But she'd grab one of them and say, that's the fourth antibiotic that was just written for him. This was in the 80s. Can you go back in and look at the other three before they have to do it? And the other one that we didn't pick up on is pharmacists. They are really great assets in the healthcare system, and they're good advocates for you. And basically, I don't know why everybody doesn't explode in the morning when they take their pills. I teasingly say, when you were a kid, you ate Fruit Loops. When you're a senior, you just get your pills, and we might as well just throw them in your breakfast bowl and throw a little milk on them and start gobbling. There's so many of them, and all colors. But anyway, pharmacists are real assets
That's great. I never thought about it. So let me go back to the care team. Is that a group of people assembled by your doctor?
Yes, usually they're the ones who invite them in, and they all need name tags, and they ought to have baseball caps. So you know who they are. And as far as the nurses go, and the nursing assistants and the LVNs, they all wear scrubs now. When I was in medical school, You could tell the Irish nurses from the other ones because they had to bend their head to get through the door. Their caps were so big. I was in Boston. We had a lot of Irish nurses, and they had these marvelous nursing caps. But now you never see one in the hospital, and it's all scrubs, and they're comfortable.
When my mother was dying, it was literally one nurse who was the most significant person beyond the doctors. My mother had been treated by a primary care physician for like 25 years, and he was part of a group, and he was never on rotation to come to the hospital to see patients during the days that my mother was in the hospital. And I really needed to talk to him because I was in a position to make a decision about whether to put my 103-year-old mother into surgery or not. And so I called and said, I realize he's not on duty to come to the hospital, but I wonder if he could come or I could just have a conversation. He never called me back. And he had been my 103-year-old mother. He'd been her doctor for, at least 25 or 35 years. That to me was a statement about the healthcare system, or maybe more about him than anything. I'm not sure.
The nurses in extended role and some of the support systems are really, really significant healthcare providers. So I had asthma from sinusitis, and the asthma nurse taught me more than I ever knew about how to use an inhaler and how to do it. And she could spend 20 minutes getting me to do it right, that I had a 15-minute office visit, and I never knew how to do it right till she taught me.
Yeah.
But people in extended roles, the diabetic educators, the pharmacists who use your drugs, the people who are now on insulin pumps, all of these support system people are really, really valuable extenders, and probably have more knowledge about the pump than the doctor.
Yeah.
So use them.
Yeah. So, okay, this is the last call for questions. Anyone else have anything else or a comment that you want to make? Mimi?
Unmute yourself.
Unmute. Mimi, you need to be unmuted.
Mimi, unmute.
There we go. Okay, I couldn't get to it. Something else kept popping in front of it. Listen, I'm just wondering, for instance, if you are in a situation where you have a diagnosis of something serious and probably terminal, but the timing and care and plan is something that you work on together with your doctor or with the specialist. But my question is, if I have long-term care insurance, what does the doctor have to do with the getting of that long-term care?
You have to usually, and this is opinion above knowledge, you have to document for long-term care the inability to do certain supportive services you need to yourself. So if you're incontinent, if you have skin breakdown, if you have a high fall risk, and I don't know all the criteria, but unless you meet those criteria, they won't pay for anything. So you have to look at the long-term care policy as to say what criteria you need to. So start wetting your pants if you need to. Buy some Depends and leave one at the doctor's office. But you need to document why you need the long-term care.
Okay.
It's all documentation.
Okay, great. All right, unless anyone else has something else. Anyone? Jean?
The focus of this conversation has been mostly HMO care. And I don't have that. And I want to put in a really big plug for the need for advocacy. Jack and I didn't have that. And somebody, not to denege or put down discharge planners, the discharge planner at the hospitals I was in, she never returned calls. She had no help with us. Jack did it all. He made the calls. He called her up and said, do the paperwork so that Jean will go to this place. And I left the nursing home on a Sunday morning because we were ready to move me. And I didn't like being there anymore. And Jack did advocacy and got me out of there. It's all, and got me into a situation that was much better. I went into a 4-week program at Summit Hospital for physical therapy and other types of therapy. It ran 7 days a week, and they managed to get me ready to go home. I can't imagine my having gone home without being there. And that was a wonderful program. But the fact that I needed to go to this, that nobody would take me on paper. I was, 75 years old. And who wants a 75-year-old woman who's had a stroke in the type of intensive physical work? They couldn't see me doing it. And yet when I got there, I was one of their stars.
Oh my gosh.
And so you have to advocate. And when they tell you no, say yes. and there were a couple times I didn't like something that was going on when I was at the nursing facility. I called Jack at home and told him to call the director. I called and left a message for the director, and I said that Jack will be calling him. And Jack called, and I tell you, we got things changed. So
I think everyone needs a Jack in their life.
they really do, but Jack and I worked as a team.
Yeah, that's great, Jean.
And I would like something changed, and he was able to help me get it changed or do the research that was necessary. I was in no shape to do computer research, but he could pull it together and say, now these are our options. What do you think? And we could make joint decisions. But you really have to do all that stuff. If you're I'm trying to say that if you're a part of an HMO, you get sort of a plan, or you can see sort of a plan of how the HMO moves people through care. If you're not part of an HMO, if you're just an old average person like we were, we thought we had pretty good coverage. In the end, we did, but it was all piecemeal. And we had to pull it together through advocacy for me and for Jack. So
thank you again. Barbara, did you have something?
I did. Jean, can I ask you, what hospital were you in?
I was in Walnut Creek, John Muir, and then I was in this other nursing care place for little over a week, and then I got moved to Summit in Oakland.
I'm really sorry you had the experience that you had. I used to work with discharge planning at John Muir Walnut Creek many, many years ago, but I certainly was not aware that people would be as left on their own as you report having been. Another role in the hospital that I'd like to bring in is hospital social work.
Yeah.
Social workers frequently can work between the departments and be your advocate. Now, it doesn't always work. Social workers are different kinds of people, and some of them, I frankly will just side with, who is the care team. But if you get one that, really, you should be able to have one that really advocates for you and talks to the discharge planner and coordinates things to have it work for you, because that is the role of support and advocacy that a social worker should fill in a hospital.
Our feeling was that the folks were just overwhelmed, and I don't know if it was because it was the beginning of COVID. It might have been. That's what we are bumping up again. They didn't have procedures for people, but it was just worked better if we told them what we wanted.
I'm glad you were able to do that.
You know,
Barbara?
I'm new to the village, but would it be absolutely out of line to go to the village where you have a lot of people who are in the volunteer program, or lots of people who would like to be there for others in the village, and see if you can find somebody besides yourself and your spouse, or yourself and one of your children, who can function in that role of advocacy for you?
You know
That's
what we
interesting.
did? My family is, I come from a very medical family. Out of 22 cousins, 15 of them are in some medical profession. So Jacqueline, I would need an opinion, need information, and I told him to look in my black book and gave them the name of the cousin that I thought would be best advice, and call them. Everyone cooperated. Everyone was just knocked themselves out to give us resources, and that was what really got us the level of care that we wanted.
Right. I'm watching the clock, and
I'll mute
I'm
myself.
sorry to interrupt, but I think I'll go back to what you said, Barbara. I'll talk to you about that. That's an interesting idea. Alan?
There was a couple chat questions, and I can go real fast. Greg and Pat asked about doctors okaying video visits. Kaiser uses them all the time. My suggestion, as I said, was if they're offering you a telephone visit, if you can do a video visit, do the video visits. It works fine. It's easy. It's as easy as Zooming. Cynthia wrote about the classes from Ollie and Death and Dying, and the other book that you've suggested, The Beginner's Guide to End of Life. I don't know what the next edition is going to be, but The Beginner's Guide was a good name. Anyway, I think that's an incredible book.
Yeah, let me just mention, it's on the list of the bibliography. It's another book that I used to conceive of this series, and it is called A Beginner's Guide to the End. And it's a fabulous doctor, TJ, oh my gosh, I thought I knew his name. I'll bring it into another session and hold it up so you can see. It's about 2 inches thick, but boy, they cover in a very down-to-earth way.
Real readable, real comfortable.
Yeah.
And then the last thing is social workers really help in palliative care too. If you have family problems and the family getting together and making decisions about where you're going and how you're going to do it and what you want, it's so much easier to have a person in between you and talking to that person with the family listening than doing it alone. So social workers are really valuable assets that and the healthcare system, back to the system, they have them, and you need to ask for them. And hospice, palliative care.
Right.
And the last word is to basically confrontation can be done without being angry.
Thank you, Alan. That's a great note to end on. And next time, Barbara Engdahl is going to lead us in thinking through the choices and what happens when you are negotiating a serious illness and diagnosis. So hopefully I'll see you then. If anyone ever has any other questions that come up that aren't answered, I said in an earlier session, ask me. I'll go and see if I can't find the answer if we're not covering something. So I welcome that. Thank you all for attending.
Thank you. And thank you, Al. for
Yes,
doing what
thank you
you're
to
doing.
Alan. Yes,
Thank
that was a rich session. I've written down a number of things, and the other I've tried to keep in my mind. Thanks so much.
Bye-bye.
Bye
Thank
for
you.
everyone.
Bye-bye.